What I'll be talking about this morning is the use of carbon fiber instrumentation in spinal oncology, and why that's a paradigm shift that is happening, and at least should be considered in the back of everyone's mind when trying to determine how to take care of patients with spinal metastatic disease, but also patients with primary diseases of the spine. So the primary goal of this talk is to highlight technology. It is not to show really weird, really cool cases or say, look what I did, but mainly to talk about what the role of carbon fiber technology is in addressing spinal metastatic disease, spinal primary bony disease. These are my conflicts. And I'm going to start off by talking about what the role of the surgeon is in addressing spinal disease. So as the surgeon, of course, this is probably a little too deconstructed, but we decompress neural elements. So whether patients present with epidural disease and cord compression or epidural disease and nerve compression, we're able to remove the disease. Sometimes, more often than not, we're also called in to stabilize the spine, whether it's to address the biomechanical uncertainty of the spine, the inability of the spine to bear loads, but also to address any pathologic deformity, very similar to the cervical thoracic junction case that you showed. And more recently, as local disease control through spinal stereotactic body radiotherapy becomes popular, we're being asked to treat essentially asymptomatic patients with epidural cord compression that need separation of the tumor from their cord in order to facilitate very, very high doses of radiation. And the reason that's more and more relevant is because the minimal doses of radiation needed to treat the metastatic lesions are almost always higher than the maximal spinal cord tolerance necessary. So the role of the surgeon to go in there and decompress essentially an asymptomatic neural element and also stabilize the area, because the treatment is inherently destabilizing, allows enough room to be there for the radiation oncologist, the radiation physicist, to be able to treat local disease and prevent, hopefully, recurrence and subsequent worsening of deficits. So what are the relevant issues for us as spinal oncologists? So wound healing is a very big issue. A lot of times, depending on where we practice, the practice patterns, the referral triages, we tend to see a lot of patients who've been radiated, who are presenting with issues. Sometimes that Thursday or Friday patient that Dr. Chapman was talking about has already been radiated or was radiated a few weeks before and is presenting late night as a pathologic fracture. So working in an inherently tough to heal environment is a big deal. So being able to address this, and I'll talk about this a little bit later, up front, becomes more and more relevant. Of course, surgery is just a step in the process. We are not the end-all be-all for the treatment of these patients. Unlike a lot of other issues in spine care, the spinal oncologist is truly just a person along the continuum of care. And therefore, knowing that the next steps in terms of giving patients good outcomes requires not only imaging for follow-up, if we're dealing, for example, with young folks who have long lifespans ahead of them, like primary tumors, or maybe, for example, a young lady with primarily bony disease, or some of these patients who have very good response to immunotherapy. We're going to not only need to image them for their radiation planning, but also image them to be able to follow up in their care. And of course, maintenance of fixation is a big deal. A lot of these patients, almost all of the metastatic lesions, will go on to get radiation to their field. So as patients are able to live longer and longer lives because of good immunotherapy, good chemotherapy, and good radiation, we're having to deal more and more with the consequences of their systemic therapy, which is typically, as relevant to us, is non-union. So fatigue resistance, so the biomechanics, and I'm hoping the issues that the question that was brought up can be answered here, or at least maybe it'll change in your mind how the question that you're thinking about asking. So fatigue resistance is very important, and that's mostly to that last point of the biomechanics. So despite being able to fixate in the area, there's really no great way to hold our fixation in place, so to speak. So that either it's because the area has been irradiated and is now infiltrated with fat and bone marrow and within the bone marrow, or it's going to go on to get radiated, and therefore it's going to eradicate a lot of the endogenous signaling molecules necessary to create a arthrodesis. On top of that, because the nature of the disease is secondary lesions to the bone, we can't use the patient's own bone to help augment any of the arthrodesis, and other adjuncts such as BMP are generally relatively contraindicated within this population. In addition to that, most of these folks are essentially osteoporotic by nature of their disease, infiltrating their bone and replacing their bony architecture. So we can expect failure more and more as these folks live longer and longer. So that's where the carbon fiber technology comes in, because it helps marry two of these big issues, which is imaging, as you can see, comparing titanium on the left with a CT scan, big starburst pattern. Imaging is very crisp. The halo artifacts related to titanium or metal artifacts in general on an MRI are also negated. And on imaging, you can see that it's relatively radio opaque. There's some translucency that allows a lot of folks like us who are traditionally trained with titanium instrumentation, with metal instrumentation, who like to see their screws, are able to still see the overall instrumentation on plain film X-ray intraoperatively. So this is what the construct looks like on a sawbones model. You can see that there are end caps going in through traditional pedicle screw trajectories. They're connected with top loading locking elements and connected with a carbon fiber rod. This is a fully carbon fiber system, reinforced with PEEK and some titanium shelling to be able to allow for visualization. So metal fatigues, and we know that from the degenerative literature, from the deformity literature, metal breaks. Inherent to all metal, even the strongest metal or metal alloy in the universe, is fatigue and breaking points. So this should come as no surprise that over time this will break. And then this becomes even more relevant in our patient population with spinal oncology, because as time goes on, knowing that the likelihood of a fusion is very, very low, the metal will undergo cycling and eventually break. So a desired solution would be to have a construct that can withstand loads in excess of what standard metal constructs do, but also at the same time be radiolucent to allow for upfront fixation. So patients don't end up going to get radiated up front because of a concern for the metal artifact causing the radiation planning to be difficult, but also afterwards, because the imaging is so favorable that radiation therapists can work around the hardware, so to speak, where they can't do that as effectively right now with high density metal implants. The other thing it does is, to that point, is because of the density of carbon fiber is low, especially as these treatment modalities that involve heavy particles like proton beam become more and more common, especially for a lot of the primary tumors, being able to give patients a lower dose of radiation is really important. And that's related to the fact that the titanium, because of its density, actually bounces a lot of these heavy particles off, and therefore requires that the what's called the Bragg peak, essentially the radiation dose, has to be titrated up to be able to account for the scatter from the metal. And you can imagine as these heavy particles are being scattered, they're affecting the normal tissue that's being irradiated. So this is the timeline of implants. We've gone from stainless steel to titanium. Now we're talking more about composites. And the biomechanics of composites are really important, because when you look at fatigue strength, the average titanium system usually undergoes around 45 million cycles before it fractures. The human spine goes through somewhere between 2 and 3 million cycles. And so the thought in a standard healthy individual is that they'll go through arthrodesis before the metal fatigues. In a patient who's not going to undergo standard arthrodesis, you're going to need something that doesn't break. And that's the relevance of using these composite type materials. And that's why we don't fly in steel aircrafts anymore. A plane, by virtue of the vibrations of not only the engine, but the air striking it, will eventually fatigue, and the old airplanes used to essentially fall apart midair sometimes. And that's why we're able to fly in airplanes built in the 1960s and 1970s, even to this day. These materials can withstand significant amount of cycling without disruption. So this is to that point again, the typical spine undergoes around 2 to 3 million cycles per year. And when you look at the cycles leading to failure, in general, it's somewhere between 4.3 million and 5 million cycles. With the current implant that's been tested that I've been using, which is the CarboClear CarboFix system, their systems were aborted at 7.7 million cycles. So is this perfect? We don't know. No one's actually tested it far enough out to see if it breaks. But the way that the carbon fiber manufacturing is performed is that individual fibers of carbon fiber are laid down with different vector directionality. So therefore, it's not that it's a homogeneous vector that can eventually, if you fracture enough of the fibers, can break, but that there's opposing and non-correlative vectors to be able to withstand extra load. As far as the imaging goes, I showed you the CT scan. This is what the MRI looks like. You can see very crisp sequences. It's a T1 sequence going through, very crisp outlines of the screw. So relevant for postoperative imaging. The importance though with carbon fiber in general is that almost all the carbon fiber systems you see out there will have some degree of titanium, and therefore using a 3 Tesla MRI is not going to be the best option in order to be able to visualize. A standard 1.5 Tesla MRI will give you very crisp imaging. And you can see over here, you may even be asking, where on earth are your screws? And you can see that faint outline of a pedicle screw right there to show what we're working with. And there's the postoperative change right there. There's the CT image. Very crisp outlines. Again, no starburst pattern. And these are relevant because these patients almost all undergo postoperative radiation. Which leads me to the next point, which is radiation planning requires imaging, and requires imaging that is crisp, that is well-defined, and therefore allows the radiation therapists to create very tight boundaries for the treatment volumes, and allows for the spinal cord itself to be visualized and allow the spinal cord to be protected. And this is something that I encountered when I first started practice, was that a lot of patients will come to us through radiation oncology, and a lot of radiation oncologists, especially in the community, will radiate a lot of patients up front, even if they need some separation, even if they need surgery to decompress the nerves or the spinal cord. And the main reason for that is because they don't want to see the titanium. They don't want to try to guess where the spinal cord is. They bear the responsibility of radiation-induced myelitis. And therefore, they're more concerned about being able to see the spinal cord as opposed to try to guess where the spinal cord is around the instrumentation. This is the effect. This is the aspect relative to heavy particle imaging, heavy particle radiation. You can see with a high Z implant, there's about 61% transmission, because about a third of the radiation is scattered away. So tissue is getting doses of radiation that it may not need or deserve. Whereas with a lower Z implant like carbon fiber, it's able to penetrate better and therefore allow for a lower dose of radiation to the tumor. So this study was one of the first studies that looked at that. You can see that there is essentially not a significant difference in terms of the screw, but when it comes to the volume between a titanium screw and a carbon fiber screw, it's significantly less, both within the body and as a whole. And this allows for standard photon radiation doses to be lowered. And in heavy particle, such as protons, this can lead the Bragg peak to be lower. You You can see much tighter targets around both photon and proton therapy. So this is what the instrumentation looks like in vivo. This is a patient with a one-level corpectomy, costotransversectomy through the left, fixation 1 up, 2 down, in the mid-thoracic spine, low SIN score. And you can see the pedicle screw with a titanium shell, polyaxial top loading system with a rod, essentially a fully carbon fiber system with very favorable imaging characteristics. Intraoperatively, you can see the screw. For those of us who like to see our screws, this allows you to see your whole screw. You don't have to draw a line from a marker to a tulip. You can see actually where your screws go and how they connect. In terms of the modulus of elasticity, the modulus of carbon fiber reinforced PEEK is the closest thing that there is to cortical bone. Now, this has benefits in terms of stress shielding, but it also has some of the benefits in terms of potentially how much adjacent segment degeneration may be involved, how much how stiff your construct is, and maybe also relevant in terms of how much a necessity there may be for anterior column reconstruction. So I was going to show a couple of the cases that I've done. This is one of the first cases that I did. This is a kind of like a test run, so to speak. It was a 50-year-old lady with metastatic breast cancer to T8, which was incidentally found after she presented with pleural effusions. She was neurologically intact, no mechanical pain. She had mechanical pain related to it as well. She thought that this was relatively just normal for her because of her cachexia and pulmonary effusions. She was noted to have this grade 2 versus 3 epidural cord compression at around T8. We took her to the OR for a separation surgery to allow her to undergo radiation treatment. You can also see this retropleural mediastinal mass on the right side. We followed the MNOP. Again, this talking less about some of the standard workup and treatment pathways and just more about the technology, but we followed the standard MNOP protocol. She was deemed to be overall pretty stable considering the location of the lesion with epidural compression, intermediate to unfavorable histology, and therefore we took her for separation surgery. And you can see and performed a strut graft in the front. Cord compression is resolved, but you can also see the spinal cord rather well through the area, which allowed her to undergo successful SBRT afterwards. And the reason to use this technology, the reason that radiolucency is so important, so the biomechanics aside, the reason the radiolucency is so important is because SBRT is playing a bigger and bigger role in local control. You can see that, this study from Tomedo was from the early 2000s, and you can see with SBRT, the local control is excellent. Even the ones at the bottom, melanoma and renal cell, they've undergone significant systemic therapy improvements through biologics, and therefore, even those, when we factor in the overall treatment, we're looking at some really good local control. And putting all this together with the patchel data, patients who get their epidural cord compression resolved, get good local control, not only are able to ambulate longer, they're able to have higher quality of life and maintain continence. So this becomes very relevant. Protecting the spinal cord, whether it's from the tumor encroaching and compressing on it or from the radiation, is very important. And that's where the technology becomes more relevant. Another case, this was actually, I apologize, this was the trial run that we did with this instrumentation at the first go around. This is a 66-year-old lady presenting with a breast met to T10. This was identified on PET imaging. She did not have any symptoms, but she was primarily sent for separation surgery. You can see one would argue not the most impressive of compression, but this would probably be considered an epidural compression grade 1C. You can see that there's a pathologic fracture associated with it. Interestingly, did not have significant compression, even though her SIN score was on the high side of the gray area. I think it was about 12 or 13. So she underwent a separation operation with fixation. You can see just barely the outline of the instrumentation. We were playing with the different rod contours. And you can imagine that unlike titanium, you cannot bend these rods. So have to deal with the different rod contours. So as a trial run, we went relatively short considering the lack of mechanical pain. She is over 1 year out and doing very well. But with her, we also learned that you want to use 1.5 Tesla MR. You do not want to use a 3 Tesla MR because even a little bit of titanium within the shell can make it actually quite difficult to visualize these on MRI. This lady is actually a little bit more interesting. So this is a T8-9, and then she initially started off as a T8, but then had local recurrence at T9. Rib head Ewing sarcoma. Presented with some chest discomfort, underwent imaging. A lesion was noted on the right side at the rib head at its attachment to the vertebral body. She underwent a VATS biopsy, which came back as a Ewing sarcoma. She underwent upfront chemotherapy. These tumors are very responsive to chemotherapy. The tumor shrunk, and she underwent an initial T8 to T8 partial spondylectomy, T5 to 11 fixation. This is what her construct looked like. Everything was going well. Something happened in terms of her follow-up, and she, I believe, did not undergo post-operative chemotherapy, which is the standard of care for these tumors. And in terms of surveillance, we tried to look to see if the tumor recurred. And I apologize, some of these images don't show up very well, but you can't really see if there's anything going on locally because of all the titanium. There's so much instrumentation, so much artifact. But when you eventually look at her through the lens of a PET scan, you can see that there's a local recurrence adjacent to the vertebral body at the level below at T9. So we took her back and performed a second partial spondylectomy at T9. My thoracic surgery colleagues reconstructed a rib. This is the immediate post-op standing images. So unfortunately, we haven't had any recent weight-bearing imaging. But you can see we replaced her with carbon fiber instrumentation. Her recurrence qualifies her for post-operative radiotherapy now. And therefore, not only does the carbon fiber instrumentation allow for her to get proton beam radiotherapy, but it allows for a better and more crisp way to image her to be able to see if she does have local recurrence. Luckily, she does not have any distant lesions, just a local recurrence that she's had. And you can see a lot of the fresh bone graft on the CT on the right. You can see the imaging is much more crisp through this area. This is her immediate post-op radiation planning simulation images. There's also a potential for cervical fixation. This is the newest cervical plate that's come out. I've done one case with it, so not a terrible amount of experience. The manufacturing process, as I described, is quite high level and requires essentially laying down of the fibers. And the manufacturing process, unfortunately, has not caught up to be able to create any screws under, I believe, 4.5 millimeters. So titanium screws are still necessary to do these. You can speak to the folks from the company, but there's a number of different sizes of plates that are available. This is the one case that I did. This was a very frail 68-year-old lady who presented with a non-immunotherapy responsive metastatic melanoma. She failed all of the more recent biologics that are used to treat metastatic melanoma. She presented with myelopathy. She had right arm pain and weakness. And she had a significant amount of neck pain. She had multiple other lesions elsewhere, but the consideration was for decompression of her spinal cord with the hope that it would improve her overall, at least local control, and maybe increase her KPS to be able to allow her to function better and hopefully undergo more of the multimodal treatment. This is her imaging. It's a little bit off to the side over here. You can see epidural disease, most compressive behind the C6 vertebral body. There's also a degenerative osteophyte there. And this cut is through C6 where there's spinal cord compression. So looking at her imaging, not a significant amount of lysis, not a significant amount of posterior element involvement. The majority of the compression is here behind the C6 vertebral body, despite some degenerative changes. Took her to surgery, did a C6 corpectomy. In the spirit of trying to do this as translucently as possible, I used an expandable PEEK cage. Focused the corpectomy a little bit more to the left side where the majority of her compression was, and fixated her with the titanium screws. And this is what the post-operative imaging looks like. The only thing you really see is some of the tiny markers on the PEEK cage as well as the screws. Now, I imagine as the technology and the manufacturing improves, that those screws will probably go on to become also carbon fiber reinforced PEEK as well. So what are the confounders with these operations? Yeah, as folks live longer, as radiation gets better, we want to be able to deal with some of these issues that I brought up in terms of wound healing. Being able to operate on folks up front because the radiation therapists are more comfortable working around carbon fiber instrumentation is good, but I think an even next iterative step would be to try to do most of these operations on folks minimally invasively. We're not looking at arthrodesis, so there's no real incentive to perform very large open operations exposing a lot of bone surface that we would hope will eventually unite. That stuff is probably not going to happen. I think focusing on minimally invasive techniques, anterior column reconstruction is going to be the name of the game going forward with these, especially as these folks live longer, like Dr. Chapman said, as these folks get better and better systemic and local care. So the potential solutions to helping with those: upfront surgery, carbon fiber instrumentation, composite material, more importantly, anterior column reconstruction, and development of MIS techniques to be able to do these minimally invasively. And with that, I thank you.